Thank you for inviting me, Siver. I spent a lot of time of my life studying the science and the art of phenopil. I'd like to answer yes to this question, but no. I'll show you cases and prove you. I have no conflicts of interest. Do not take picture, please, of this patient. They didn't allow me to show them here. And I'll show you the first case. She's 56 years old, and she complains about retids, hyperpigmentation, and sagging. I made her full-face phenylcrotinoid pill, 1.6%. Her evolution was typical, nothing special. On the 4th day, 5th day, nothing special. On the 10th day, nothing special as well, unless some ulcerations. 17th post-op, okay, post-inflammatory erythema, that's normal. But on 4th, 7th day, she asked the clinic to come back with this aspect. As you see, we see post-inflammatory erythema, that's normal, hypochromia, and perifollicular repigmentation pattern. That was a big, really problem, this close-up. And then on 74 post-op, she improved a little bit with corticosteroid topical and sun avoidance. And then 1 year later, dyschromia, hypopigmentation, and hyperpigmentation in some area. We see here the evolution, 1 year evolution with delayed healing plus dramatic dyschromia. The next case, number 2, she complains again about retids, hyperpigmentation, and sagging. I made her full face, phenylcrotinoid pill, 1.6%. The evolution was okay as well, nothing special, but 4 months during the follow-up, she called me, and I said, come here in the clinic, and I saw this firm erythematous, painful, itchy, very itchy plaques, bilateral. I did intralesional triamcinolone, topical clobetasol, vascular laser, and occlusion. Then 1 year later, you see here on her right side, that's her serpiginous elevation with telangiectasia, but now asymptomatic. It's hypertrophic scarring. And I did intralesional 5-fluorouracil. Case number 3. She came to the office and said, I got these lesions after the pill 3 months ago. She was billed by another physician and got this hypopigmented area. We saw here through wood lamp and the normal view, these hypochromic and erythematous macules bilaterally. I did a biopsy. I saw no melanocytes and no fibrosis. That's good. And here, after treatment, 1 session of latanoprost, intralesional. I got a little bit result. And number 4, the same and a really delayed healing process that was disturbing for her because it was very painful and itching. So what these 4 cases, these 4 patients, what did they have in common? Harfaction, madarosis, frontal recess, tubular perifollicular scale. What's that? FFA. Please. What they don't have? Stem cells, hair follicles, and sebaceous gland. Do not build those kind of patients. They have erratic process of healing. Avoid medial and deep pills. And examine always the scalp to look for early signs of FFA. It's so important. So for those kind of patients, phenol is not relevant. About acne scar, phenol, it's not relevant as well. I don't see good results with it. Here, 3 cases before and after. It may be good for those, the 3rd case, small lesion, small scar, but for example, I would never peel the first and the patient in the middle. Rolling scars can improve, but improve occurring just during edema and then they relapse. Some miscellaneous, here 1 patient, she has static wrinkles, dermatochalasis, fat pockets, and sagging leading to deep nasolabial folds and marionette lines. Phenolpil, it's relevant here only to static wrinkles. You can have a good result, as you see here, but when you start doing phenolpil, you don't want good result, you want the best result. So for us, it's not enough. Here, the side view. This other patient he has as well, but she has tear throw. It's not good for those on red, and it's good for static wrinkles. And look before and after, she still has static wrinkles. What happened here? Muscle. They need to be aware that botulinum toxin is mandatory, okay? If they are against botulinum toxin, avoid those patients. The other one, heavy face. Avoid chemical peeling, phenol peeling on heavy face, if they want to treat that. Globular fixed wrinkles, tear throw, infraorbital wrinkles, deep nasolabial folds, and marionette lines. Here before and after Baker-Gordon formula. What you see? Only overall improvement of the skin. Attention with those heavy skin. What aging signs does she have? The same, but here she has a little bit dark eyes. Phenol can improve that. Here, before and after, you still see globular lines, a good improvement, but not enough. What does she need? Botulinum toxin and filler. Another view. For those wrinkles around the mouth, it's good. Another patient, globular wrinkle, and a heavy face, it's very heavy. Another patient with good result, but 5 years between those photos without botulinum toxin. Regarding ectropio, if the patient want to treat skin, look for excess of skin on the lower eye. You can if you don't have snapback test, if snapback test is negative, you can cause ectropium. It tends to improve during the treatment, but it can happen. It's not relevant for those kind of patients. Another 2 cases of ectropium. And regarding phototype 4 and 6, we do, but if you don't do phenol yet, do not start with them. That's a risk. Post-inflammatory hypochromia. Post-inflammatory hyperchromia, it's really not a complication. During the process, it's normal. We treat. Do not be afraid of melanocytes. But post-inflammatory hypochromia, it's a big problem. And again, periocular signs, chemical peeling do not improve fat pockets, neither tear throw. Dermatochalasis of upper eyelid, it improves sometimes. Tear throw, for those patients, they must be aware that they can improve the overall quality of skin, but not all signs. But chemical peeling, who is chemical peeling for? Here you see good results. If the right patient is chosen, you have great results. And this is the ideal skin, thin skin, phototypes no more than 5 parallel wrinkles or rhomboidal wrinkles. That's the perfect patient. Before and after, good results. Nothing in dermatologist can produce that. If you choose the right patient, you can achieve best results ever. For those patients, it's relevant or not? The first one, yes, but not to these bags. The other one, yes, it's relevant. The third one, yes, but she has FFA, so don't. The first patient with those acne scar, I wouldn't promise her a real improvement of those acne scars. The other patient, yes, this seborrheic keratosis will disappear, but she has a heavy face. The other patient, yes, she would have a good result, but probably she will need filler. Really, really good indication, the first one, with surgical procedure, blepharoplasty. The other patient has a heavy face, no, and the other one, yes, mostly because she has these dark cycles, it's good for her. So thank you.